Thanks a lot, Nancy. Yes, I became involved with behavioral health and primary care about 4 years or so ago in Jefferson City. And we identified that there was a real problem. What I was seeing in the hospital side of things is patients were just being admitted, readmitted to the hospital for pain-related issues. There was very little coordination of care. And then certainly you've seen in the news, almost every day you're seeing stuff in the news about pain medications, overdoses, the prescription drug problem in America. So we have really been trying to tackle this issue head on. And in the state of Missouri, we are way out in front of every other state in the union as far as how we are implementing policies. Today I'm going to talk to you about some of the things that we've done, share with you some of our experiences, just kind of go over some of the different words and terminology and different philosophies that we use with our patients to hopefully help you to better care for some of the patients that you see, to help you to better coordinate the care of the patients that you deal with, but also to educate yourself so that you in your own lives can see what pain is, how you treat pain, how you deal with it. And it amazes me that so many people, they just kind of think that pain is just like any other disease, like it's hypertension or diabetes or something like that. And you just give somebody a pill and it all goes away. Well, pain isn't like that, and we'll touch on that. About the first 30 to 40 minutes or so of the presentation, I'll kind of go through my slides, but please feel free to ask a question if you think of it. But I do have a lot of time at the end that I would really like to engage you guys in discussion and talk about different things. I have some of my people that I've worked with here interspersed in the audience, Dr. Stuckemeyer over there, Dr. Saeed right here, one of the psychiatrists from Jefferson City. So please feel free to ask a lot of questions as we go through. So I think anytime we talk about pain, we have to kind of understand and define what pain actually is. Pain has always been part of the human condition. You look in the Bible, you look in all throughout antiquity. People are always trying to treat pain, assign some sort of definition to it, find some way to treat it. Why are we experiencing pain? Is it a cultural, religious, any type of thing that can be acknowledged to pain and why we experience it. But in the late 70s, the International Association for the Study of Pain came up with this definition. And this is kind of the accepted definition right now. It's a sensory and an emotional experience associated with actual and potential tissue damage. When we touch that hot stove, we sit there, we know it's hot, we move our hand. That's protecting us from burning our finger. But it's also, there is an emotional experience with that too. You can probably think back when you were a kid, your mom told you not to touch that hot stove. So you know in your mind, if you touch that hot stove, it's going to be hot. So there is a lot of memory involved with pain. Our experiences affect how we deal with pain. So it's just very important to realize that there is emotions involved with pain. Also, there's a big difference between acute and chronic pain. All of us in this room have experienced acute pain to some extent. Broken our arm. The females in this room may have had kids, had surgery. We all know what pain is. We can think back, I'm sure you're all thinking in your minds right now, to a moment in your life when you had pain. We've all experienced that. Not all of us experience chronic pain. Chronic pain, by its definition, is any acutely painful situation that lasts greater than 3 to 6 months. Acute pain can transition into chronic pain, but the question is why? Why does this happen to some people and it doesn't happen to others? And then, how do you treat it? Because what has happened over the last 15 to 20 years or so is that physicians, healthcare providers have tried to treat chronic pain as if it were acute pain, and we're going to go into that in a minute here. And then, of course, there's cancer pain, which is a completely different entity. Cancer pain, most often, many times, terminal illness, that really changes how you deal with that patient's pain. it just is a completely different situation. I'm not really going to get much into that today. Of course, obviously, emotions are involved with cancer pain, dealing with their diagnosis. But it is more, it is an entirely different treatment philosophy, in my opinion. So in 2011, the Institute of Medicine came up with a report called Relieving Pain in America. And they discovered that pain does affect 100 million Americans. So if you think there's 250, 300 million Americans, that's roughly a third of the population is affected by pain in some way, and it is a significant cost in the many billions of dollars. And you see it with disability claims, with lost days at work, the cost to the healthcare system. So it's clearly a significant problem in the United States right now. Again, you see this all over the news. It's daily. It's in the news. The other thing that they decided in this report, though, is that in order to treat pain better, there has to be a cultural transformation in how pain is perceived, how pain care is delivered, how pain is treated and researched, and all those things. So the key piece in that report was cultural transformation. Like I said before, we tend to think of pain as a medical condition, so we can treat it like any other medical condition. We can, when someone has diabetes, we give more insulin, or someone has hypertension, we increase their blood pressure medication. That has not found to be the case with pain. So, taking a few steps back here, back in the early 2000s, the late 1990s, Congress passed a law, and President Clinton signed it into law, that the 2000s would be the decade of pain control and research. And that's where you got to see, you may have experienced this when you've been to the hospital, they always ask you, what's your pain score? And that's why that came about, is that pain was going to be the fifth vital sign. It's as important as measuring somebody's blood pressure, as important as measuring somebody's heart rate. That this has to be at the forefront of every healthcare provider's mind, is their pain. Well, there's a big problem with that. It was a cart before the horse situation. We were asking all these people if they're in pain, but no one could agree on how to treat their pain. And so it led to a lot of problems. If you see from this slide here, comparing 1991 to 2009, significant increase in the numbers of prescriptions of hydrocodone and oxycodone. So it's, tripled at least there. So the United States is the most massive user of hydrocodone and oxycodone in the world. I think they use more than the rest of the world combined. So is that necessarily a good thing? We've identified that people are in pain, but are we treating them? Well, the answer to that, I think we can safely say, is no. More is not necessarily better. We just think that if we give more, that's going to be the right thing. And I'm experiencing that right now in Kansas City. The hospital I'm working at, about 4 or 5 years ago, they noticed that their patient satisfaction scores around pain were really bad. So what they decided to do was, okay, we'll just make sure every patient gets whatever pain medications they need at any time. Well, now their pain satisfaction scores are worse than they were 3 or 4 years ago. So that's why they asked me to come in and help them out with that. And then you see here, too, back in 2012, the CDC report said that deaths from prescription opioids now exceed the deaths from automobile accidents. So clearly the more is not necessarily better thing is definitely true. And then just this summer, the CDC came out with that deaths from opioids have increased more than 5-fold in women from 1999 to 2010. So going back, pain is the fifth vital sign. We're asking the question, but we're not sure how to treat it. So it'd be like if you ask somebody, or you see that someone's blood pressure is high, but you don't know how to treat their blood pressure, you need to do a better job of that. So the other big problem we're obviously seeing is opioid diversion, and diversion means they're taking the medication and using it for its unintended reasons. And certainly theft is a big problem. There's been a big increase in crimes associated with opioids. I have a very close friend who's a prosecutor in St. Joe, Missouri, and he deals with this all the time. And he said it's just the case logs from theft and crime related to opioids is just it's very, very high. And of course, people get a prescription for it and they start using it for non-medical reasons, which I'm going to go into in a minute here. In Missouri, I always like to talk about this when I'm speaking to a Missouri audience. We are now, unfortunately, the only state in America that does not have a prescription drug monitoring program. Every other state, a physician can get on a drug monitoring program and see if a patient has gotten an opioid prescription from some other provider. We can't do that in Missouri. The only way we can do it is if the patient is a Medicaid patient and they paid for their prescription with Medicaid through Cyber Access. But that doesn't always work because sometimes patients will pay cash for their prescriptions. So there's really, you have a patient come in and they say they're in pain and you want to help them. You don't, you just assume that they're being truthful, and sometimes you get burned by that. And certainly there's significant risk associated with these medications. Patients with sleep apnea, COPD, a history of substance abuse are far more likely to have problems associated with their opioids. Certainly with sleep apnea and COPD, what we're seeing is patients don't wake up the next morning after they take a dose of their medications. So again, goes back to the more is not necessarily better situation. Then there's a ton of misinformation out there about what is an opioid. And I really like to hit this point hard with any audience here is the definition of the terms that I use. You've noticed that I've been saying the word opioid. Well, sometimes people refer to those medications as narcotics. Well, narcotics is a legal definition. You have the scheduled narcotics, that's determined by the DEA. Opioid is more a definition of what the medication does. A benzodiazepine is a narcotic, according to the DEA. But in most people's frame of thinking, it's not a narcotic. But we have to use the right terms with the medications that we're prescribing. Then I see this really bad, it's very unfortunate, where I'll hear healthcare providers say that a certain opioid isn't a narcotic. And so the patient thinks, okay, that means it's safer because it's not a narcotic. Well, guess what? It is an opioid. I've seen that with Vicodin. It's a Schedule III, so it can be called in to a pharmacy. Doesn't make it any less dangerous than any of the other opioids. It's still an opioid receptor agonist, just like heroin is, or just like morphine is. It's just the DA in their infinite wisdom has decided that for whatever reason you can call that in. I know that many states are looking at changing that. But for example, the medicine tramadol, that's an opioid agonist as well. It doesn't have as many risk factors for abuse or misuse, but it is still possible to abuse or misuse that medication or develop an addiction to it. So it's very important that the healthcare providers understand the pharmacology, and it kind of reminds me of if you watched the baseball game last night, everyone in there who watched the game last night knows that if you take Cialis and experience an unsafe drop in blood pressure, that you need to call your physician. Nobody knows that stuff with opioids, so we need better explanation to the healthcare providers and the patients of what they're taking. And then this is kind of my George Bush word is misprescribing, because we see that a lot as opioids are being treated as first-line therapies in really inappropriate situations. I've had patients who come to me for a referral or a consultation where first episode they've ever had of back pain and they're on high-dose oral morphine for low back pain. Why is that? Well, I'll ask the patient, why? How'd you get on this medication? I mean, this is so far outside the norms of medicine. The patient will say, well, that's what the doctor gave me. I said, well, what did you tell the doctor? Why did you give it to him? Well, I told him it was the worst pain I ever had. Well, that may be the case, but do we need to give you something that end-stage cancer patients need? And the answer to that's probably no. But again, it's this misprescribing situation. And the World Health Organization does have a chronic pain ladder, which kind of, I hope you can, it's really hard to see back there, but it's tiered, obviously. And so in the first tier, you have physical therapy, over-the-counter medications, things that the patient maybe could do on their own. The second tier then is prescription NSAIDs. And then in the first tier is psychological therapy. But people forget about that. Psychological therapy is a very important first-tier treatment for pain. Then, of course, nerve blocks and different things that I sometimes do in my clinic, injections, various things. Opioids are further up the ladder. That doesn't necessarily mean they always should be used, but it is further up the ladder. And then, of course, there's advanced pain therapies that my neurosurgical colleagues can do, different surgeries, implantable devices that can help with the truly chronically painful situation. But I think it's really important here to really hit home the difference between acute pain and chronic pain. And this is where community support workers, mental health providers, primary care providers can really help educate their patients is the difference between acute pain and chronic pain. I get patients all the time who come in and they say their pain today is 10 out of 10. Their pain has been 10 out of 10 every day for the last 15 years. It's very unlikely that I'm going to do anything that day to make them better, to reduce their pain. And so now you have the situation on the acute pain side where a patient gets hit by a car and they end up in the emergency room. Now that's, to me, is 10 out of 10 pain because they maybe broke their arm or fractured their pelvis or did something really severe. Now that's 10 out of 10 pain. The patients kind of lose sight of what really is, of what their pain is. Is it this acute situation or is this a chronically painful situation? One of the things that some of our behavioral health specialists will do is if a patient who's in chronic pain comes in and says that they're 10 out of 10 pain, they'll just kind of say to them, well, so if I punched you in the face, it would not be possible for you to have any more pain than that. Sometimes the patients will say yes. Okay, so that's clearly a different situation that we have to start dealing with. And so that kind of segues here into probably why I'm here. The close coordination between pain and mental illness. As you see from this slide here, almost 50% of patients with a pain disorder experience anxiety and depression. So clearly, chronically painful situations, there is a mental health component to it. Doesn't mean that the pain is in their head. It doesn't mean that they're not experiencing the worst pain of their life at that moment in time. It just means that perhaps there's other factors involved in their pain, and certainly a pill, an injection, doing something right then and there is probably not going to make a big difference for them. And this is where the psychological component of pain really factors in. And certainly in my practice, what I've seen is that undertreated mentally ill patients, it is nearly impossible to treat their pain, in my opinion. I get patients all the time who come in who they've been bouncing around to various specialists, bouncing around to various physicians, and no one has ever asked them about their psychological pain or their psychological condition or any underlying psychological problems. And sometimes it upsets me. It used to upset me more, now it just upsets me most of the time. But I can think off the top of my head, I've had many patients who came in to me, one patient in particular, a young girl, probably in her mid-20s. She had spine surgery for a supposed herniated disc. Didn't work. She still had pain afterwards. She got on high-dose pain medications. Then that physician didn't want to treat her anymore, so sent her to another physician. She bounced around to 5, 10 different physicians. I just asked her, have you ever been emotionally, physically, or sexually abused? She broke down crying, saying that she had been sexually abused as a 9-year-old girl. I was the first person to ever ask her that question. And you'll see here that, actually I'm going to jump ahead here to this slide, but there's an increased risk of chronic pain in patients with a history of childhood sexual abuse. Physicians don't think that, because what happens if you're a regular primary care physician, and you're in the room and you have 35 patients to see that day, the last question you're going to want to ask is, were you sexually abused as a child? Because you've asked that question, now what are you going to do about it? And so a lot of times these patients, they bounce around to many different physicians. No one's ever addressed what probably is the real heart of the matter of why they're experiencing some of this pain. And certainly patients who do have a significant history of psychological trauma as children are at increased risk of substance abuse. And I'll back up here to this slide here. On the substance abuse thing, the 51% of those who met criteria for a substance abuse disorder at some point in their life also met the criteria for a mental disorder. So a lot of these patients are using some of these substances to treat some underlying psychiatric, very painful and disturbing symptoms. It's really easy for a patient to say, you know what, my back hurts, rather than saying, it hurts up in here in my mind, or they're thinking about some psychologically traumatic event that occurred when they were children that was never appropriately addressed. I had a patient who came in. He was involved in a motor vehicle accident. His fiance died next to him. He survived. He said that I got into it with him about this. That was when, of course, when his back pain started. And I just discussed with him, he never had any counseling after the accident. The fiance died, and her last words to him were, "Don't ever forget me," and all these things. He never appropriately processed any of that grief and never grieved the situation. And so his body's way of reacting to that grief was just to say he had back pain all the time. Yeah, there was some degenerative disc disease in his back and maybe some things, but certainly the main problem for him was this grief and inability to move on from that terrible accident. We got him into counseling. I saw him about 3 months later. Of course, he had no pain. He had properly grieved the whole situation, was able to process it. Of course, he was emotionally and psychologically healthy other than this episode. You take a patient who is not psychologically healthy, and you put a traumatic event on top of it, then you put some sort of pain-related condition, those patients can be very, very difficult to treat. And certainly giving them a pain medication just to get them out of your office is not going to be the right treatment approach for that patient. Yes? Well, the thing is with patients, they're not dumb. They've quickly figured out that if they say their pain is 10 out of 10, that they're going to get something. If you walk into the doctor's office and you say your pain is 0 out of 10, you're not going to get Vicodin. And so they think that they know. They've been to enough physicians, they've been to enough ERs to know what it's going to take to get the end result that they want. Because in their mind, they think that's all that's going to work for them. And so what we work hard with patients doing is focus more on, and I'll get to that here in a minute, but focus more on functionality and different things. Like we'll talk to patients and say, they'll answer functionality questions much better after the second visit, and we'll hit that hard and say, well, you're 25% better here because you're now doing more of the things that you weren't doing beforehand. So I'll get into that more in detail in a minute here. But your point about the subjectiveness of pain is a very good point, because what my 10 out of 10 pain is way different than yours. And then the person asking the question, their 10 out of 10 pain is different too. So, you see this in the hospital where a nurse who's on the cancer floor, she knows what 10 out of 10 pain is, patients who are dying of cancer. Your back pain is nothing compared to that. But that patient doesn't know that. So we'll get to that here in a minute. So it's really important here with my patients that we get a very thorough history and physical. We need to know their past medical history, psychiatric history, substance abuse history, any significant comorbidities, physical comorbidities. Patients who are unhealthy physically are going to be more difficult to treat. It's going to be much more difficult to treat their pain too. So, and this is all part of that patient-centered medical home stuff, which I'm going to get into that in a minute too. But the patients, you need to ask those questions and help volunteers, get the patients to volunteer information. And it's difficult to discuss psychologically painful events in their lives, but it's very important that it is discussed. Because when we can better identify what is actually causing the pain and its associated conditions, now I can start doing things. I can start figuring out, okay, what sort of diagnostic tools do I need to get? Do I need to get an imaging study on their back? It's just not a reflex situation. You have back pain, okay, we're getting an MRI. That may or may not be necessary, but sometimes it isn't. And so by getting a detailed history, we can more appropriately, we can save money too, because if everybody who has back pain gets an MRI, that would obviously bankrupt the system. And then also, in the exam room, we need to take note of any physical signs and symptoms that the patient is experiencing right then and there, and then on physical exam too. You can't discount anything you see there. certainly very important to use some screening tools with those patients. I know I don't need to talk to you guys about this, about depression screening and various things, but primary care physicians sometimes aren't using that, the depression screening. We use PHQ-2 and PHQ-9, and it's very effective for us because then we can identify the comorbid conditions. And then the other big thing, too, is the opioid risk. There's a lot of different tools that can be used to assess opioid risk. We use something called the Dyer score, which can kind of look through different social things, psychiatric, physical signs, different things that can kind of help us to decide whether or not this is an appropriate patient. Because when you're going to prescribe opioids or take opioids, you have to understand, is this a good patient to get this medication? Is it the right patient? The right patient at the right time is kind of the new buzzword out there for opioids. And so opioid risk assessments have to be done on these patients. And if I were a patient, I'd probably want that done on myself or my family members, because sometimes with opioids, it's a very long-term problem. And when patients start taking opioids, they experience that pain relief that maybe they never got before, or that, and I'm speaking of pain relief, psychological pain relief sometimes. Sometimes they'll take the medication and they'll say, this is what I've been looking for my whole life. And that maybe isn't an appropriate patient. They may have, those patients I would argue are probably more susceptible to addiction or misuse or abuse because they're using those pills, those medications to treat underlying psychological problems. I had a patient this morning, demanded that I give her Vicodin, demanded it, said that was the only thing that was going to work. I said, well, why do you want this medication? So I can help take care of my kids. Well, that's not an appropriate use for Vicodin. She was taking it because she was having stress related to her kids. She had some knee pain, but it wasn't anything out of the ordinary. But in her mind, she had developed this relationship with the Vicodin helps her get through the day. And you've seen, you could see that when the CDC came out with that report about women with a 5-fold increase in opioid-related problems with women, is that they interviewed a bunch of women. They found that they became supermom when they took Vicodin. Well, that's not really the right use of Vicodin for those patients, because they're using it for an inappropriate reason. They're using it for the euphoria that you get. Those patients are going to be at significant risk for problems down the road. And what I would tell a primary care provider is, you prescribe this medicine one time. Are you ready to continue to prescribe this medication forever? If you have this patient for the rest of your career, are you willing to have them come in every month and give them this medication? If your answer to that is no, then maybe you shouldn't give it to them. And so that's where the opioid risk assessment can really help with that. And then again, of course, we want to assess functionality, because what I don't want to ever see with patients is that they go home and sit in a recliner and just take their pain medications all day and never get out of that recliner. They have to be functional. If we have patients who say that they pass all the opioid risk assessments and they're deemed to be an appropriate candidate, we want to make sure that this medicine is actually helping them. It's continuing to help them with their functionality. And probably the worst patient in the world to get an opioid would be somebody who just sits at home all day in the recliner watching TV. That is not going to be a good long-term patient. So, again, very important, very, very important. I cannot stress this enough, is that it is so important to assess the patient's psychological fitness. Patients who are unstable psychologically, their pain is going to be exacerbated by their unstable psychological illness. They're going to be more difficult for me to treat, for their primary care physicians to treat, and then I would argue also more difficult for their behavioral health providers to treat. So it's very important that we do all get together and talk about particular patients, and so that's kind of what we've done in Missouri here to do that. Once, again, well, like I said, once we've diagnosed the patient, the appropriate treatment strategies can be determined. So who is the best provider to manage this patient? What we have done in our clinic is kind of determine, is it the primary care provider, is it myself as a specialist, or is it the behavioral health consultants? And many times it's all three, sometimes it's 2 out of the 3, sometimes it's just 1. But by doing that appropriate assessment, risk evaluation, it's much easier to determine who is the right person to kind of spearhead the treatment of this patient. Unfortunately, with many of the patients that we see in the community health setting is that there are significant barriers to care. The patients lack insurance, they may be underinsured, they can't get a referral to a specialist somewhere. Certainly the unavailability of psychiatry, it just is, there are a lot of barriers to this patient population. And then, of course, the patient's socioeconomic factors. They may not have the ability to go make appointments. They can't miss work to make appointments. And then it can just be a long time to get in to see a specialist. So what we've done is kind of modeled our pain care after that patient-centered medical home situation. We call it patient-centered pain care. So it's a biopsychosocial approach, not a biomedical. So the psychological side of things is very important. The patient is a person. Sometimes physicians, I'm sure I've been guilty of it in my career, is that, I remember back when I did anesthesiology, we would say, we have a gallbladder to do on Monday. Well, it's not a gallbladder, it's a patient, but that's just what people say. And so you kind of forget that. There's a bit of an echo here now. We kind of forget that that patient, it's a patient who needs to have their gallbladder removed. And so it's not some procedure, it's actually a person. And then what we also try to do is get the patient very involved in the decision-making process. That you share the power with me, that you are here by choice to see me, that this is an alliance between the two of us to get you better, or the three of us, however many people are involved in the patient's care, to get you better. And when patients can kind of buy in that they're part of the decision-making process, that does improve the delivery of care. It's not a one-sided thing. It's not me telling you what to do. It's you taking an active role in making yourself better. And then I've also found, too, it's really important for the patients to kind of understand that the physician does have feelings and is empathetic. One of the techniques that I'll use with patients is say, you know, it's frustrating for me, too, that I can't make you better right now. I would love to be able to say, here's a pill, you're going to be able to walk out of here, and you're going to be 100% perfect. But we have to understand that that's not reality. You know, I'm human, too. Medicine, there is no 100% cure for all illnesses or all problems that exist. And if patients understand that, they can buy into that, and they can say, okay, well, I know you're doing your best. And that helps them to kind of appreciate that sometimes the job of a healthcare provider is hard work, and that we're not being mean. We do want to help them. It's just that there's limits to what we can do. And it's definitely a team approach, what we really practice. And this is where community support workers, any behavioral health care providers can be heavily involved in this, is the team approach. If you're taking a patient to various doctor's appointments, you can be the person who says, you remember that time when we went to Dr. So-and-so's office and they said you need to be doing this? You bring that up in the doctor's office. And because patients are sometimes overwhelmed, they forget stuff. And it's very important that anybody who is there to support the patient can help to improve that communication among providers. I see it all the time among healthcare providers that no one talks to anybody. And sometimes they need that. They're busy, and it's kind of one of the big problems with the healthcare system the way it is people just don't talk to each other. So anybody who's available that can help improve that communication is really important. So in kind of society today, taking a pill is equated with relief of some whatever symptom. We need to move away from that. It's not necessarily the case. It's not true with depression. It's not necessarily true with hypertension, diabetes. Patients can improve their diabetes by improving their diet and not taking a pill. I see patients all the time who say they're pre-diabetic. I say, well, what does that mean to you? Well, it means I need to improve my diet. Okay, well, we're treating your diabetes without a pill. Yeah, we could probably give you some pill and it would improve your thing, but that's probably not a good long-term strategy. Pain is no different. You can't just give somebody a pill and expect all their pain to go away if they're just going to go home and sit on the couch all day long. And certainly with patients, there are obviously the reasons why they're experiencing pain. So there's different interventional approaches that I do in my office that can help with their pain. What I'll tell patients is we want to get you to your baseline. I don't even know what your baseline is, but I want to get you there. And so this is something that I think would help you get to your baseline. And then there's certainly the alternative approaches, which I think are highly effective with patients who are dealing and suffering from chronic pain, and that's yoga, meditation, massage, and prayer. There's been countless studies that show that those are very effective in the treatment of pain without doing anything else. And then, of course, the behavioral approaches too, which I've obviously been hitting on here. It's very, very important that all of these approaches are encouraged by people who are involved in their care. Family members, therapists, community support workers, and of course the primary care providers. If I have a patient who comes in and says, yeah, I go to the chiropractor once a month and that really helps me, I say, great, keep going to the chiropractor. It's not bad for me to say that you shouldn't go to the chiropractor. If it helps you, go. If it helps you to stand on your head 3 times a day, do it. Whatever helps you. And so if patients are encouraged by people they trust, family members, and if they can be supported in that way, they're going to know that this is some other treatment modality that they can do other than just taking a pill. And so what we have done in our clinic is to say, are you making all of your counseling sessions? If you're not, why? You said you came in, you say your pain is worse, but you haven't been to see your counselor in 6 months. Maybe that's what you need to do. So it's very, very, and then we'll have family members who come in and they say, they haven't been to I notice they're more depressed. I notice they're having more problem, and they're experiencing more pain. They'll encourage the patient to go to their counseling sessions. So it's just very, very important to encourage any and all available therapy. In the physician side of things, historically it's been looked down upon that a patient would go to a chiropractor or a patient does some of these alternative type treatments. In my mind, whatever works. Taking some pill you got off the internet or something works and it's safe or whatever, it's not causing problems. If it's like one of these supplements or something that you see, as long as it's not bankrupting you, you think it helps, take it. It's not going to bother me. If there's some contraindication, obviously I might say that, but certainly all available therapies should be encouraged. And I've found that in patients who are really suffering from truly chronic pain, they just want a plan. They've been bounced around to so many different places. They just want a plan and somebody to listen to them. And whoever that person to listen to them could be. Many patients who suffer from chronic pain don't have that support system at home. They rely on visiting the doctor's office or rely on visiting their counselor for that interpersonal relationship that they're not getting at home. I have a patient who, she comes in to see me, she used to come in to see me all the time, and she'd come in, she got dressed up every time, and I just asked her one time, gosh, you always look so nice when you come in here. I really appreciate that, that's nice. And she said, well, this is the only time I get out. So, it kind of made me think, okay, well, so the nurses understood that, and they liked the interaction with her because this to her was her social experience for the month, essentially. So we talked to her about, well, maybe I consider going to church or finding some sort of support group somewhere. And then she never really thought of that, and it was just her way of getting out. She was stuck in her apartment all the time, not doing anything, and so that obviously made her feel better. So what happens when we try this approach and pain is not controlled or relieved, and we do see this a fair amount. And so that's where I really rely on my psychologists and social workers and counselors to help me with the patient. Because we do get patients who we try this approach and just nothing's working. And so what we'll do, some of these psychological concepts that we'll work on with our patients are the concepts of perception, suffering, and recovery. Psychology is such an important part of dealing with chronic pain that it's just so important that you use some of those concepts with your patients, and physicians are notoriously bad at doing that. And so what I have done is really focus with many of the primary care providers that I work with on using some of those psychological concepts. It's easier for me, my undergraduate degree is in psychology, so I understand, and most physicians, their undergraduate degree is in biology or biochemistry or something like that. So But the issue of perception is patients all think that they're the only one who's ever experienced anything like this ever. And it kind of goes back to what I talked about, the patient who comes into the hospital and says their pain is 10 out of 10, and the oncology nurse sees the patient and they know what 10 out of 10 pain is. And sometimes it just helps saying, well, you know what, I've seen other patients like you. You're not the only person who's ever experienced this. And sometimes when they get that awareness that, yeah, they're not the only one who's ever experienced it, does help with some of that recovery. Patients just, when you're hurting and you're in that area, you just think that you're the only person who's ever experienced that. And patients, especially the ones who have psychological illnesses, they have a hard time understanding that other people are dealing with things that may be similar. And that's where the advantage of group therapy or support groups does come in. And certainly after the physical pain is long gone, and this kind of goes back to my previous slide on the emotions and thoughts factoring into more with chronic pain than acute pain, is that psychological pain can persist for many, many, many years, and sometimes it never goes away. And patients want that psychological pain to go away, but I always tell patients that the pain you're experiencing isn't like you just had your gallbladder removed or your appendix taken out. This pain is something that you may experience for the rest of your life. I'm going to help you to manage it better, and I'm going to give you the tools that you need to help manage it better, but this is something that may go on for a long, long time, and you need to understand that. We don't want you to suffer, but you need to understand, you need to move on. It's like with a death in the family. Sometimes patients, they don't understand that an acutely painful event that turned into a chronically painful event, they never grieved that situation, kind of like a death. You know, you just kind of go through those different stages of grieving that you've kind of accepted that this is the reality of the situation, and you can kind of move on from things. And sometimes patients have never been approached in that manner, and they just understand, they think that, well, medicine should be able to fix me, when that may not necessarily be the case. And certainly you see that a lot more in patients who've suffered significant spinal cord trauma or traumatic amputations. If they can kind of grieve the loss of that limb or grieve the loss of function, then they just do better. And then the whole idea of recovery, relief versus function, giving patients realistic expectations about what can be expected here with our treatment. I'm not going to promise them that I'm going to take away all their pain. I get that from the surgeons all the time. The patient comes in and says, well, the surgeon told me that after he did this back surgery, my pain would be completely gone. Well, that's not a realistic expectation. You're still overweight, you still smoke, you don't exercise. You're probably not going to get better with the surgery if you don't make some other changes. So what's realistic? We have patients who came in and they say, all I want to do is be able to, play tennis or something like that. Well, they're 85 years old and their knees are bad and they can't play tennis anymore. So, you know, it's just, we have to kind of reestablish things. You know, I oftentimes will say to patients, I'd love to make you like you were when you were 25. We'd all like to be like we were when we were 25, but that's just not possible. We have to look at what is realistic here with getting you better. I know that there's things that we can improve on, but we have to kind of, again, move through this thing of acceptance on what is realistic here. So I've left my contact information. You guys can write this down if you have questions for me afterwards you don't want to ask, but I'd like to really open it up here to discussion. And like I said, Dr. Saeed, who's a psychiatrist who's worked with me extensively, Dr. Stuckermeyer, who's worked with me extensively, are both here too, primary care, psychiatry. So if you have questions, please, by all means. Yes? What do you do about the physician who is more than willing to give somebody pain medications when you think it's inappropriate? That may be a scenario where you could go to the physician after or before the appointment and say, I know some things about this patient that maybe you aren't aware of. Because physicians, this is the feedback I get all the time from primary care providers, is they're kind of locked in, they're busy, they have a million other things to worry about. they're not thinking about stuff. They are just focused on getting the patient out the door. And it is a heck of a lot easier to write that prescription than to sit and talk to the patient for 45 minutes when you have 5 other patients out there waiting to be seen. But in my mind, it's not appropriate medical care. What you can say is maybe discuss with the physician's nursing staff, maybe discuss with, use your role as, identify yourself. I'm this patient's community support worker. I'm very much involved in this patient's care. I have some concerns. I think they'll listen to you. And maybe that physician will be appreciative of it because they don't know about any of this other stuff that's going on. They don't have time to ask. They don't want to ask. Maybe they don't want to know. But certainly take your role, use it, and don't be afraid to speak up. Does that answer your question? Yeah, he caught in the middle of it. Yeah. Right. That's a difficult situation, certainly one that I've seen frequently. But maybe it's a situation that you could have a meeting with everybody involved and say, I've had patients who come in who are on medications like that, and the support worker says, maybe that's not the right approach for you, in front of me and in front of the patient. And the patient says, oh, no, I need that. And then after discussion, me leading the discussion, the patient comes to the realization, you know what, everybody else is telling me that this isn't the right thing either, so maybe I shouldn't give it. It's all about approach and how you talk to the patient. Again, I'm not kidding myself. I know that many physicians will take that approach. Well, I'm not giving it anymore if you think there's a problem. But there's ways to go about it, and you just have to nuance it and figure out what's the best approach for that particular person.
For a patient who's been on the opiates for, let's say, 15 years, because that's how their primary care physicians are treating their pain, and obviously partly psychological, like, what is your suggestion, like, when you go and see somebody else, if you can actually get the patient to change doctor, even get a second opinion, like, how do they come off that? Is it just like an immediate stop of the opiates, or should they be, I don't know.
Well, it's different for every patient. I'll get that a lot. Like, I'll get a patient who comes in and they'll tell me they're out of their pain medications tomorrow or something, or the doctor wrote the last prescription a month ago and he said you would finish writing them. Well, how did he know that? Because I've never seen you. But the patient, I'll do a risk assessment on the patient. Sometimes it's riskier to continue writing the medication than it would be to just stop it and let the patient go through withdrawals, get it over with. If they experience severe enough withdrawals, go to the emergency room. Whoop. Sorry. Those patients who are severe enough, if they get inpatient, that kind of tells them the gravity of the situation, that, yeah, you had a problem, you need to come off of those medications. I've had a couple of patients in the last few weeks who were on very high dose medications. I just had them admitted for 3-day detox. They were, saw them a week later, they were so much better. And I would have just been perpetuating the problem, kicking it down the road for somebody else to deal with. And I'm not going to do that in some patients. Now, a patient who's been on them for a long period of time, they're psychologically stable, there's no other issues, you can consider tapering it down, and that can certainly be done, but sometimes it's just deciding who that patient is. And there's a definite fear of withdrawal, but fear of withdrawal is not a reason to continue prescribing a bad medication, because there's significant risk involved. If they're psychologically unstable, they go home and take too many pills and die. So, yeah, you just have to kind of assess the risk on that patient. So again, back to the how do you approach the physician who wants to continue writing the pain medications. Encourage the patient to get a second opinion. Yeah, that's tricky. Yeah, you want to answer that?
There's always have somebody in the communities where they want to prescribe the pain medications. And then I struggle that on a regular basis. So what I have done is have meetings with these primary care physicians on a regular basis. Like the gentleman was saying that, well, if you call this physician and tell them that so-and-so patient, she's abusing the medication, so of course the physician is going to stop it, then is not going to, serve the purpose because this patient is not getting the medications, the, withdrawal and everything like that. But if you have some coordinated care, if you meet the primary care physicians in the area on a regular basis every 2-3 months, and then talk about the common problems the common patients are going through, especially if somebody is abusing the medications or like Dr. Haake said that they're just taking the medication and doing nothing, just sitting at home. So it gets easier as we coordinate the care with the other physicians on a regular basis. So I think that's a very good thing that if you meet with them on a regular basis and discuss the problems of the community with the pain medications. It's not easy, but you can start that way and then down the road, hope for the best.
One of the things that we've done is to say that to use the support workers, to have them meet with my nurses to kind of decide, what's appropriate care. And so that can be encouraged. If you have a patient who's, a bunch of patients who see this particular physician, you can maybe spearhead that. Say, I'd like to meet with one of your nurses once a month to discuss our challenging patients. I don't see how they could say no to that. Did you want to add something, Katie?
I work a lot. I've worked with Dr. Haake for almost a year now over at Kreider, and I'm a primary care doctor. I get a lot of caseworkers coming to appointments with me, and one of the best approaches that I've seen in being able to address an opioid problem kind of behind the scenes is sometimes they'll slip me a note. Sometimes they'll grab my medical assistant before the appointment, and they'll say, here are my concerns, and usually I might even meet with them before I even go in to see the patient and say, give me the lowdown of what you know, what you've seen, why you think we need to change something. And they can give me this information, and they will give me usually a very heart-to-heart look that says, I have a good relationship with this person that I do not want to burn. And almost always I can find a way in that room to kind of elicit the information that they directed me at without seeming like it was given to me. And that's usually not very hard, and especially if you give them objective information like, did you know that they were in the hospital 3 days ago and just got a script for 40 tabs? Or did you, which violates a lot of prescribing contracts. That's an important piece of information. Or did you know that, they're kind of really sedated every time I come and see them? Or, these kind of facts that I could go look up or I could claim to have sort of found on my own. It kind of pull you out of the blame game of why that wasn't appropriate, but yet the end result is the same. Also working as with the healthcare home, I'm one of the physician consultants there. We will use that role and that meeting sometimes to address issues with outside physicians. So if someone brings up the point that we think this person is diverting it, we're pretty sure, we've gotten reports from the family, this and that, we don't always make the CS be the front runner in this situation with this provider. Sometimes we'll write a letter, and I'll sign it as the healthcare home physician consultant to say, just kind of an FYI. Are you aware that they are, getting opioids from multiple prescribers? They were admitted for an accidental overdose on this date. This on the record is extremely convincing to a prescriber. Okay? Because now they know somebody's watching, And now I've got a letter that is now in somebody's file somewhere that says, you have warned me that there might be a problem. This is very convincing for a lot of providers. So just a couple of ideas that I know CSs and I have worked on in our organization. And our goal is when we think it's inappropriate for a patient to be on an opioid, we try to dead end them in multiple formats. If they decide to switch providers or something like that, their chart note is going to follow them, that information is going to follow them, because ultimately we believe they shouldn't be on it because we can serve them better and treat their pain better in other ways. Usually trying to always remind them that our door will be open. If you change your mind and you want to come back, we'd happily pull you into our pain management. So just a couple of suggestions that we've used over at Kreider.
Yeah, that's a very, very good point of we present the patient a treatment plan and we'll say, okay, this is what we recommend for you. It's your decision whether or not you want to follow it. And we've had so many patients who they leave, they go back, they realize that they go somewhere else, they realize that nobody's going to give them the kind of attention that they need. They'll come back and they'll buy into the treatment plan. And once we get that buy-in, it makes it so much easier to treat their pain. And it just makes everybody's life so much easier. Those patients become a real joy to treat because they know that you are really trying to make them better. And they just have that buy-in that they know that there's more than just the issue of the physical pain, that there's other things going on too. So the big key, though, is the care coordination among all the providers. And I would say that anybody involved in dealing with this patient is part of the care coordination, whether it's a support worker, whether it's a family member, whoever is taking care of this patient needs to be involved in some of the decision making. And so in the patients, if they understand that, and you're up front with that and say, you tell the patient beforehand, I have some concerns about some things. You seem more depressed. You seem more sedated. You don't seem like yourself. I'm going to bring this up with your doctor today. And I think they'd appreciate that. Some people, they don't want to talk about bad situations or bad things that are going on, but at least you've made the effort. And you can't really be 100% of things to 100% of the people. You just have to do your best. So, yes. Well, certainly many of the things that I talked about before, best practices would be depression. Are those physicians even asking about depression or any behavioral health stuff? Are they assessing functionality? Are they the patient's just coming in, saying, oh, you're good, and here's your script for the day? Is there any type of exam or any type of... Yeah. It just depends. There's like Oswestry Disability Index is what I typically use for functionality. Just different questions, percentage improvement. Do they stop smoking? Are they exercising? Are they changing their diet? Any verifiable things that can be shown that the patient is taking an interest in getting themselves better. And then what was your first question? Oh, the contracts, yes. Okay, so again, this kind of goes back to terminology. I don't like to use the word contract. I would rather say it should be an agreement because that implies that it's a two-way street here, back to what I was talking about, the therapeutic alliance. If you say that it's a medication management agreement, that sounds much better than contract. I'm always big on what words I use and stuff like that with patients because the contract implies a little bit of negativity, that if you don't do this, you're not going to get your medications. And so there's ways you can spell out that agreement that, again, gives the patient buy-in. And then if you have a patient who comes in and, for example, they test positive for illegal substances or something like that, instead of saying you're going to fire the patient, which many of those contracts state, you use this as an opportunity to improve the patient. Now, why did you feel the need to use illegal substances? What's going on? Do you need help? we can get you help. We can do things for you. I'm still going to take care of you. It means that maybe we aren't going to give you any more opioids, but certainly there's different things that we can do to help manage your pain. And we've had that before. I've had patients who have violated the agreement. It doesn't mean that I'm going to kick them out of the office. Now, sometimes we've had patients who were physically or abusive to some of the staff, or now that's one thing. I mean, that's more of a, ask them to leave. They typically don't come back. But yeah, it should again be more of an agreement between providers. So, yes. Yeah, it's very, very important that that everyone is speaking the same language when you have a problem. One of the things that we've worked on is from top down, from the CEO all the way down to the person answering the phones. This is an approach that our entire organization is going to use, because what patients will do, they can be manipulative. They will use the friendly person who answers the phone that they have somehow figured out is the person who's going to give them what they need, versus the physician who's going to say no. They'll play off each other. And so it's just really important that everyone is speaking the same language. Anything else? Okay. Well, I think we're close to being done. So thank you very much. I hope you learned something. And like I said, if you have any questions, don't hesitate to give me a call. I'm always happy to answer questions, and we can sort it out. So thank you.